Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Brian Rade, and I'm a naturopathic doctor. And today I am joined by a fellow naturopathic doctor colleague, Dr. Drew Timmermans. Dr. Timmermans practices on the west coast of the US of A. And to my understanding, his practice is primarily working with orthopedic concerns. So he does lots of different injection therapies, works with peptides, and I've been following him on social media, particularly on Instagram for a number of years now. He's always posting interesting things, talking about the interplay with, maintaining proper hormone levels to optimize injection therapy outcomes, and helping to resolve orthopedic concerns. I've messaged him a couple of times about a couple of patient questions, and he's been generous enough to get back to me on that. And he just really seems to be an expert in this area. So I've been looking forward to chatting with him for a little while now. In terms of, how does talking to an orthopedic specialist, relate to complex chronic illness? Well, at the end of the day, a lot of patients, in my experience with complex chronic illness, especially as they're recovering from complex chronic illness, they can start to have just kind of quote unquote regular people concerns. Their, arthritic joints might start to take more of a priority as their chronic fatigue and their neurological symptoms and MCAS symptoms and things like that start to get better. And then unfortunately, in some cases, especially if there are chronic infections afoot, sometimes there can be some, say joint degradation aftermath. There could be maybe a expediation of joint degradation over the course of the illness. And in my experience, I do a lot of injection therapies as well, like prolotherapy and ozone therapy, perineural injection therapy, things like that, can be really helpful at certain stages along the way. Or even if someone's in the throes of their chronic illness, they might have, say, had a pre-existing arthritic joint, and then now it's just, it was like a 6 out of 10 if 10 is bad, and now the dial's turned up to 9 or 10 out of 10, and we need to start, working on that to help get them out of pain. Also, some of the something called perineural injection therapy, which, to my understanding, is something Dr. Timmermans works with as well, can be really helpful for folks who are suffering with fibromyalgia or other types of more like neuropathic pain. So there's definitely some application of this chat to the complex chronic health issue world. But then, of course, some folks listening don't have complex chronic health issues, or they used to have them, or they have family members, but they might apply to other folks. So hopefully this episode will be of interest. I'm looking forward to picking Dr. Timmerman's brain, and we'll see what information he has for us today. Just before I bring him into the conversation, I just want to remind folks, in case you're not aware, I do have a course that an online course that's available. It's a course about basically navigating the waters of complex chronic illness. And if you sign up for my newsletter, the link for which is below in the show notes, or if you're watching this on YouTube, it's below in the description of the video. You can sign up for my newsletter and get access to the first 2 modules at no cost. The course covers a range of topics, including Lyme, co-infections, heavy metals, chronic digestive issues, histamine issues like mast cell activation syndrome, mitochondrial dysfunction, a whole bunch of other topics. So if you're interested in that, please sign up for the newsletter. And I send newsletters every few months or so, just about little tidbits that are coming up in my practice, things that I'm excited about, upcoming podcast episodes, etc. So definitely won't inundate your inbox with messages, but I send them out from time to time. So if you're interested, please sign up. So I will pause the recording here, and I'll be back in just a moment with Dr. Timmermans. All right. Well, welcome back to the podcast, folks. And I'm now joined by Dr. Drew Timmermans. Dr. Timmermans, thanks for joining me today.
Thanks for having me on, Dr. Rade.
It's my pleasure. I've been looking forward to this chat. Just before we jump into my questions, do you mind just giving listeners a little background on who you are, where you practice, and what kind of things you do in practice?
Yeah, so originally hail from Canada. So as we were talking before the show started, southwestern Ontario. So lived there until I decided I was going to go do naturopathic medicine. Initially, my sights were on allopathic medicine. I hadn't been exposed to naturopathic medicine through, high school, undergrad, and stuff like that. And then I applied for allopathic med school, had some interviews, didn't get accepted. And so I worked as a personal trainer at Good Life Fitness for about a year while I was, beefing up my resume, studying for the MCATs again, all that type of stuff. And one of my clients had noticed how excited I got when I was able to help patients, reduce their blood pressure meds or their cholesterol meds or whatever it was through the lifestyle changes and exercise stuff that we were doing. And she's like, "Hey, you should really look into naturopathic medicine." And I was just like, "I don't really know what that is." Went and searched for it online, and just reading like the 6 tenets of naturopathic medicine, I was just like, this resonates with what I believe medicine should be. And so instantly I was just like, where can I go to school? How can I, start doing this? And I had some interviews, looked at Toronto, looked at Vancouver, and then had an interview out in Arizona. And this was in March. And so, going from Canada to Arizona in March is a big selling point. And so
Indeed,
I was just
indeed.
like, all right, this is where I'm going to go. And so started med school. I'd always had a passion for orthopedics and sports medicine. I ran track at Western. And so, that was a big part of my life. And but I didn't really know how sports medicine and naturopathic medicine fit together, when I first started. And so prior to coming out to med school, I was actually on my way home from CCNM's Discovery Day and was in a car accident on the highway. And then, like a week later, I herniated a disc. And so, kind of the car accident weakened the annulus, most likely, and then ended up herniating a disc in the gym a few weeks later. And so, that started me on my own chronic pain journey. And so in second year med school, I went to a AAOM conference out in Florida for sports medicine. And at that conference, I was still having chronic pain, got diagnosed with an iliolumbar ligament tear and a tear in my trap fibers, and got treated with PRP at the conference. And within 3 months, I was pain free. And it was the first time in like 2.5 years that I was pain free. And I was just like, holy crap, this is what I want to do for the rest of my life. And so that started me on this whole journey into treating chronic pain predominantly with what we now call orthobiologics. Some people still just call it regenerative medicine or regenerative injection therapy. It goes by different names, but essentially injecting things like dextrose prolotherapy, platelet-rich plasma, and then stem cell therapy from bone marrow and adipose tissue. And we use that to help patients improve the integrity of structures that the brain is registering as painful. So a lot of orthopedic complaints, knee osteoarthritis, neck pain, headaches, low back pain, and then your kind of more traditional orthopedic stuff like rotator cuff tears, patellar tendonitis, things like that.
Awesome. That's a good backstory. As far as
Thanks.
backstories go, that's definitely a good one. Um, well, I've got a bunch of questions for you. And just before jumping into those, just reminding listeners that nothing that we're talking about today should be construed as medical advice. This is all for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. Um, so as far as I'm going to call it regenerative injection therapies because that's
Yep,
usually what I call it. But so
perfect.
orthobiologics, that sounds very cool as well. That's the term you
Same,
use. Is
same,
that right?
same,
Yeah, same,
same.
same. Yep. That sounds cool though. So, actually, I was chatting with my resident a couple of days ago, and we were talking about the mechanisms of action of, how does, say, prolotherapy work or how does PRP work, and we were, taking a look at all the different cytokines and growth factors and things like that they found from, in vitro studies and things like that, or animal models or whatnot, and just how would you explain to a patient, like if someone comes in to see you, choose to inject, between the two of you, decide, okay, I'm gonna, do some prolotherapy, I'm gonna do some PRP, and then they come back and say, hey doc, my knee's feeling better. How would you explain to them like why their knee is feeling better in all likelihood?
Yeah. Yeah, good question. So I think probably the avenue that I tend to take is that, when we do these injections, we are re-stimulating a new healing response. So the body's going to go through the inflammatory response first. And so that's important to tell patients before the injection because, if they're not told, hey, you're going to be sore for 3 to 5 days afterwards, they're like, wait a minute, why am I worse? This didn't happen with a steroid injection.
Mhm.
So we go through that inflammatory response, and then they get the tissue remodeling and collagen deposition and things like that. And in that process, we are going to get some structural improvements in the tendon, the ligament, the joint, things like that. And some of the some of the stem cells that get recruited to the area. So when we do prolo or we do PRP, there's evidence to show that we're getting migration of local stem cells into that area that are naturally already present in the body. Those can secrete different growth factors and signaling molecules that can help to modulate inflammation in that area. And so we can get a reduction in inflammation. But I think a combination of this, this biological reduction in inflammation, as opposed to just a suppression of inflammation that we see with NSAIDs, corticosteroids, things like that, along with actually improving the tissue integrity. So, we're improving the stability of the ligament, we're reducing or eliminating some of that tendinosis that can occur. Those things there, the brain is now going to register, hey, there's less damage, there's less stimulus coming from this tissue, so I can downregulate those pain signals that the brain is interpreting.
Great. And some patients come in to see me and they say, like, oh, I heard that, you can inject this stuff into my joint. Like, I've got, moderate arthritis or bone-on-bone arthritis. And, I heard you can inject this stuff like this Prolo or this PRP into my joint and it's going to like regrow the cartilage. And I'm assuming in your years of practice, some patients have come in at least asking you about that, or that conversation topic has come up. And just to further dovetail, I mean, I have seen a few case reports, not I've never seen anything published, although if you know something published, I'd love to see it or hear about it, of like, some before and after radiographs, like suggesting that maybe we can stimulate some cartilage regrowth. But what's your, if somebody came in saying like, hey doc, can you like inject some stuff that's gonna, regrow my cartilage in my knee? What would your response be to that?
Yeah, so there is some interesting literature suggesting and showing that in some patients, sometimes we do get regrowth of that cartilage, or we get, true repair of that, the rotator cuff or things like that. There's actually just a study published this year by Chris Centeno, where they did a bone marrow, PRP, and platelet lysate combination for high-grade partial and full thickness non-retracted supraspinatus tears. And they were able to show that about 75% of those patients actually had improvement of that supraspinatus tendon on a second look MRI. And so there is evidence that we do get this and that it can happen. However, that's generally not what I tend to focus on with patients, because there's also evidence, in some of the studies where they showed, let's say, a little bit of cartilage thickening that didn't always correlate with improvement in symptoms. And so even in that, in Centeno's paper where they're looking at the supraspinatus tear, there were a few patients that actually had worsening of their rotator cuff on that second look MRI, but all the patients that had a worse looking MRI were functionally better. Their pain scores were lower, their functional scores were lower, and so there doesn't seem to be this match. And so generally what I talk to when I'm with patients is, hey, well, that's obviously our ultimate goal. Like the true goal is actually to get you to be able to do what you want to do, and that requires less pain, and that requires more mobility, more functionality, and so that's our target endpoint. Now, interestingly, there is a study that was published out in France by Philippe Hernigou, who is arguably the father of regenerative medicine. He was the first one to use bone marrow for non-unions, so fractures. He then did it in avascular necrosis of the hip, and so he's really, I would argue, is the pioneer of all these orthobiologics, especially the bone marrow. And they did a study where he took bone marrow. And so in the same patient, bilateral knee osteoarthritis, he took bone marrow on the one knee and just put it inside the joint. On the other knee, he put it inside the bone. So he did what's called a subchondral injection into the femur and the tibia. Then he looked at pain scores and functional scores over 2 years, which showed about the same improvement. But what's really fascinating is he looked at what's called the survivability of the knee over a 15-year period. So basically, intra-articular versus intraosseous, and which of these knees progressed to a knee replacement over this 15-year period. If you got just intra-articular alone, you had about a 70% chance that you would need a knee replacement within 15 years. If you had intraosseous alone, you had a 20% chance of needing a knee replacement in 15 years. And so that's one of the things that I also try to focus on with patients is, hey, while we may not be actually reversing any of these cartilage changes, if we can delay the progression of these cartilage changes with our approaches, then we're now actually changing the outcome of this disease, which is a knee replacement. And so those are kind of the things I focus on as opposed to saying like, hey, we're going to regrow your cartilage or things like that, because that may not matter, and may not be our end goal here. I think our end goal is pain, function, and delaying disease progression.
Yeah, I couldn't agree more. And I'm just curious, that study that you just mentioned, was it just a single injection and then they waited for 15 years?
Single injection.
I see.
Yeah,
Okay.
which we love seeing.
Um, True, like good to see the power of that. At the same time too, then just more functionally, because I know one of the I don't know, maybe criticism's too harsh of a word. I mean, you're originally Canadian, I'm Canadian. We don't want to be too harsh, with anyone here. We keep mind our P's and Q's here. But I find that it's a little bit, not really real world applicable necessarily. Like quite a few of the PRP and Prolo studies that I've seen anyways, like they'll just do that single injection and see what happens. Whereas in clinical practice, it's like, by golly, if I could only inject a patient once, it's like I wouldn't help nearly as many patients as I have, if I was only able to do one treatment. So I'm just wondering if you can maybe speak to sort of, a study like that saying like, yeah, like, oh, yeah, it's interosseous, like, okay, yeah, it's packs more punch than the intraarticular alone, but how does that kind of translate into real world practice where we're probably going to be injecting someone more than once in all likelihood?
Yeah, yeah, good question. So I think there's two layers to this. The first layer is the difference between a bone marrow stem cell treatment and then PRP and even prolotherapy. And clinically, what we see is that that the stem cell therapies are going to be the strongest therapies, and so they have the highest percent chance that a single injection will give people the results they're looking for. Compared to PRP, sometimes it's one injection, but most of the time it's going to be 2 or 3 injections. And then prolotherapy, that's generally, going to be anywhere from 4 to 10 treatments, depending on, what's going on and the severity of the condition, how intense the pain is and all of that type of stuff. And so when I'm counseling patients between Prolo versus PRP versus stem cell, that's one of the things that we factor in. I have a lot of patients who travel to me from outside of Arizona and even outside of the US. And so if somebody's coming in and they're like, hey, I can't come see you every 6 weeks for prolotherapy, even every 3 months for PRP might be difficult and now cost prohibitive. Then we might say, okay, well, here's the data on bone marrow stem cells, and this, has a higher percent chance that you don't have to come back to see me. But if you do, we can do a repeat bone marrow procedure 2 years in, or we can do a PRP booster at 9 months if your results are kind of lagging. So I think that is one aspect of it. The other comment I have is that generally what I will do is, so I like being evidence informed as much as I possibly can. And so when I'm talking with patients, I show them this data and I say, look, this is what it looks like off a single injection. However, this is not what happens in clinical practice. We're not just going to do this once. And if 6 months later, you're not, you're only 20% better, we're not just going to be like, well, we did our one injection. Yeah, that's what the research did, right? We're going to say no. Like at that time point, if you're not in the group that is having outstanding results, we're going to look at repeating this injection, and improving that. Or if I look at studies that are like a single PRP injection and they show a 50% improvement or reduction in pain, I show that to patients and then say, but then look, wait, once we get to that 50% and you plateau, we're going to treat you again. So we're going to add on top of this. We're not just going to do one injection and then go, look, you got your 50%, see you later. We're going to repeat these injections because we know that we can compound the effects and the results.
Great. That makes a lot of sense. One question that some folks might be having, and you kind of alluded to it earlier, but I just want to ask you just sort of point blank. So if someone's listening thinking like, yeah, like, you're talking about all these different injections, but like, I've seen my family doctor or, orthopedic doc or something, and like they gave me a cortisone shot and like it helped right away, or maybe it didn't help. But yeah, let's say like I had an injection already with cortisone, it didn't help. So like, is this stuff even applicable to me? Or, I had a cortisone shot and like, yeah, I get those and they help. And like, I get one every 3 to 6 months or something. And like, why would I do regenerative injections instead of just like that quick and easy? Like, yeah, I don't mind getting a shot every 3 to 6 months, especially if my tax dollars are paying for it north of the border where,
Yep.
the advantages of socialized healthcare. So, any comments on either of those scenarios?
Yeah, the patients that we work with, I'll say most of them have not seen the results that they want from the conventional system. So they're in that scenario where, or one of the scenarios I should say, is where they have the cortisone injection and it didn't work. If that's the scenario, usually what I do is, and we do this with every patient, but what I'll really focus on in that patient is the diagnosis. So someone might have knee pain. They get an x-ray that shows knee osteoarthritis. Doctor puts cortisone in it. It doesn't do anything. Well, it's probably because the pain in your knee is not coming from directly the cartilage surface, right? You could have a sprain in your MCL, or you could also have a meniscus tear, and the coronary ligaments or the meniscotibial ligaments that attach that meniscus down onto the tibia, which are usually the reason that meniscus tears are painful, that could be the cause of your pain. And so the steroid didn't actually treat the cause of the pain. And so we got to step back, look at the diagnosis, reevaluate that, and then plan our treatments accordingly. So that's kind of one group of patients we have. The other group of patients we have is they are, let's say they have, well, I'll keep with the knee osteoarthritis example, is basically the doctors told them that, yeah, you're just going to get these cortisone injections until it's time for knee replacement. And the patient goes, but I don't want a knee replacement. What can we do outside of that? And the doctor goes, well, nothing. Like it's symptom management until we can do the thing that cures your knee osteoarthritis, which is to get rid of the knee. And they're not happy with that. They're not satisfied with that answer. And then the other group of patients are the ones who recognize and understand that there are detrimental consequences of cortisone injections or corticosteroid injections. There's plenty of literature now showing that when you inject this cortisone inside the knee joint, for example, that it's actually going to speed up the degenerative process of that cartilage, and it's actually going to speed up the time for you to get a knee replacement. And so it's not treating the root cause, it's just symptom management. And so, some people are okay with that. We have there's a lot of patients who don't come to our clinic that clearly they're okay with just having the steroid injection until it's time for a knee replacement, because that's just their personal view and belief about medicine. And that's fine. And we respect that. But we're here to help the people who are not satisfied with the results they've seen, or they don't want to just continually degenerate the joint, even if it gives them 3 to 6 months of pain relief, and they just want a different alternative.
Okay. Just one quick question about meniscotibial ligaments, which I've never really thought of before now. It's one of the many reasons I
Ah,
enjoyed podcasting because I always learn something when I'm talking to my guests.
yeah.
And I'm just wondering when that is the pain, the pain instigator or the pain driver for a patient, does just intra-articular injection cover that, or do you need to orient your needle in a certain way to try to get in between the meniscus and the tibial surface, for example?
Yeah, so in our opinion, and most of the literature will support this, if you put something just around a ligament that's damaged or a tendon that's damaged, it doesn't tend to do as well as directly getting into that ligament or that tendon and directly treating it. And so I would argue that you want to get directly into that ligament. It's a relatively easy ligament to treat. So even if someone is doing palpation guided approaches, it's really just palpating that joint line and then feeling where that tibia is, and then you can just pepper along basically that joint line on that. If it's medial, go medial, or lateral, go lateral. And then under ultrasound, you can see that ligament really well, especially when it's damaged. It's nice and thick. It's right underneath the meniscus, and you can see it attaching down to the tibia. And so under ultrasound guidance, which is what we use for this, we'll go directly into that ligament and kind of put little aliquots kind of along that whole ligament.
Cool. Okay. And just one other kind of quick question, I think. So, when folks are getting their say radiographs back of their knee and say there's, the report will typically talk about the lateral, medial, and subpatellar compartments of the knee joints.
Yep.
Do you find that it matters where you insert the needle? If, say, like someone had mostly subpatellar loss of joint space, do you have to insert the needle subpatellar, or can you just go through a, lateral or medial approach or something, and it doesn't really matter because it's all the compartments are contiguous? Or do you do you find it works better if you place the needle in the compartment that's the most problematic? And then, sorry, part two of that question would be, if someone had, say, tricompartmental degeneration, do you insert the needle into all three compartments to give them the best bang for their buck?
Yeah, so because the knee joint capsule is going to contain all three of those compartments, if we are doing an intra-articular injection, it doesn't matter where you get access to the joint. So under ultrasound, the most common place we're going to actually do it is the suprapatellar recess, which is nowhere near any cartilage. But when you inject into that, all of that fluid will flow down into the remainder of the joint space and will bathe kind of all three compartments. Now, there is some animal literature showing that when you inject stem cells, those stem cells can adhere to the place where the injection is occurring. And so there are some docs out there who, when they're doing like a bone marrow or an adipose stem cell procedure, if it's mainly for medial compartment, they will target directly the medial compartment. They'll do a very slow injection. They'll actually try to position the patient to where gravity is helping the fluid to stay against that. I don't know if that is going to change clinical outcomes. Obviously, there's the animal literature showing that the stem cells will adhere to the cartilage better in that area. We've done that sometimes, haven't really done it for the majority of cases, just because, again, if you look at arthrograms, you look at contrast spread, when you're doing these injections, when you go into your needle is on the medial side, that contrast is going to go to the lateral side. It's going to go to the patellofemoral joint space. And so it will hit all three. Where in our practice, the location really matters is for those intraosseous or those subchondral injections. And so if somebody has medial knee OA, we're needing to put that needle into the medial femoral condyle, into the medial tibial plateau. Or if they have patellofemoral, we make sure we get inside the patella for our injections and things like that. But if you're doing intra-articular, in my opinion, it doesn't matter where you put that needle and get the fluid in.
Makes sense. I guess just a follow-up to that, just more like just geeking out for one sec. So bear
Yep.
with us, audience, here. I just gotta
We've
ask this
lost a
because,
lot of people, but it's okay.
yeah,
It's a good
probably, but
conversation.
no, that's okay. I mean, I'm happy, you're happy. It's at least two people are happy here. So I've had a handful of patients, not many, but a handful over time where, say I was injecting, either like a lateral approach or medial approach with, say, PRP or Prolo. You always have ozone in the mix as well, and in my practice anyways. And we're getting like okay results, but then but they have, say, subpatellar involvement as well, and they're like, oh, the pain just seems, like, when I'm asking, like, well, where does it still hurt the most? It's like, well, it seems to be under the kneecap, so I'll still do a lateral or medial injection, but then I'll also inject subpatellar as well. And again, only in a handful of patients have I needed to do this, but it seems like that doing both injection types gives them then the results we're looking for. And I just, when I put on my thinking cap, I figure like it's probably just because I'm injecting a higher volume of fluid and everything. But just wondering if you have any, do you think it's just because I'm injecting more solution and that's probably doing the trick? Or I don't know. Just wondering what your thoughts
Yeah.
are.
Are you doing ultrasound, palpation, fluoro? What are you doing?
Just palpation.
Palpation. Okay. So, and I'm assuming you're coming subpatellar, like from underneath the patella up.
Yep.
Yeah. So what you're most likely getting is they might have a little fat pad impingement or fat pad inflammation, which right underneath the patella is the most common location that you're going to get like a Hoffa's fat pad impingement or inflammation. And so when you're coming up under the patella, you might be putting some stuff into that fat pad as well, because that fat pad, when you inject into it, feels identical to when you inject inside of a joint, because the fat is, just is not very dense and compact.
Yeah.
And so it's possible that you're getting some stuff into that fat pad region, and that fat pad can be a huge driver of pain in those patients with patellofemoral pain. And so that could be one aspect of it. The higher volume could make sense as well, but if I had to guess, I would probably say it's a effect on the fat pad that you're getting.
Okay, cool. And I actually want to ask you about fat pads, but I just had
Yeah.
another question that came into my mind. I've thought about this over the years, and just pick your brain on this because I've got you here. My understanding is that when it comes to Prolo solution, typically the highest concentration that I've ever heard anyone talk about, anyways, is usually like a 25% dextrose solution. And I'm just wondering if you've heard of anyone, or if you yourself have used like a higher concentration than that, if there is any benefit to going higher concentration than 25%.
Yeah, the only time we on one patient we did a higher concentration, and we actually did just straight 50%. But our reason for this was that they actually had a tear, and so they had a Baker cyst. They had a tear in the actual cyst, and so they were leaking joint fluid down into the calf,
Oh
and it
no.
was super painful for them.
Yikes.
And so we did 50, and this was when I was in residency. We did a 50% dextrose solution into the joint, really to just try to sclerose that tear down. And that gave some moderate relief. And then we actually went and injected the 26.4% saline, which is going to be even more hypertonic than the 50% dextrose, and injected that in. And I think it was like 3 rounds that we ended up doing with the patient, and the patient, ended up doing well. Now in practice, what I would do is I would find that tear under ultrasound, and I would put a really high dose of PRP around the outside of the tear in conjunction with inside the joint. But that's the only time that we've ever really gone higher than 25%. And truth be told, I know we're all trained that 25% should be in the joint, and then 15 to 20% outside the joint. We really don't have data on that, right? If you look at some of the studies that have looked at, intra-articular prolo, and there was one study that actually had a second look arthroscopy that showed some cartilage regeneration with monthly injections of dextrose. That study, if I remember correctly, it was either 15 or 17.5%. It wasn't 25%. Other studies that look at it, they'll use anywhere from 15 to 20%. And so I don't even know if 25% is the optimal concentration for an intra-articular injection. I know it's what we're all taught, it's what almost every single person does, but I still don't know if that's actually the best concentration for us to be using. And so I haven't done anything higher than 25%.
Okay. Well, if I hear of anybody who has, I'll let you know. Well,
Thanks.
see how it goes, but yeah. Um, and another question I have for you. So if someone's listening, and I know I've encountered this in my practice, where someone will come in and they'll say like, oh, I've got, they're coming in to see me for, I don't know, headaches or something or whatever, and they're like, their review of systems like, oh, I've got knee pain. It's like, okay, what's happening with your knee? Oh, yeah, I have arthritis on my knee. Okay, well, just so you know, I know you're here for headaches, but we do, regenerative ejection therapies, blah blah blah. And they're like, oh yeah, like I went down to Florida and I had PRP or something like that, and like it didn't work for me. It's like, okay, like, well,
Mm.
what did you like, did you have like one injection, or like how many per knee or whatever? Like, oh yeah, they just injected it right into the joint, and like I had a couple of treatments and it just didn't work. And then in those cases, I'll, depending on their wants and needs and the vibe in the room and all that, sometimes like, well, we got some time, like, can I just take a look at your knee and I'll palpate and find some, extra articular, and for folks listening, outside of the joint, tender
Yeah.
points, like kind of digging around the knee and finding some tender points. And then so we'll have the conversation of like, well, it could be that the pain driver is, as you were saying, like, not inside the joint. And so in a lot of those cases, we wind up doing some injections. We inject some points outside of the knee, and lo and behold, they get better. And so, with that preamble out of the way, I'm just wondering, how often is it that someone will, you'll find that the main pain driver, whether there's, significant arthritis or some inside of the joint problem, or not, like that the main pain driver is actually outside of the knee. In case folks listening,
99% of the time.
99, okay, that's a high
99% of the
percent.
time, there is a extra articular outside the joint pain driver as well. And a lot of that's just because the cartilage is not innervated. Cartilage can never be painful. Generally, what's painful in patients with knee osteoarthritis is actually the subchondral bone. That bone interface. So you've got obviously, like, you've got the femur, so you got bone, and then you've got cartilage, then you've got joint space, cartilage, bone. it's really that subchondral bone that gets painful. Whether there's a little bit of edema and some microfractures in that, which would be called, bone marrow edema or bone marrow lesion, or the cartilage has thinned enough such that now you have exposed bone that's rubbing on the other cartilage or also rubbing on bone. That's what ends up being painful as an intra-articular source for osteoarthritis. And so almost always there is extra articular or outside the joint contributors to the pain. Most of the time, what we're seeing is those coronary ligaments, the meniscotibial ligaments. MCL is a big one. And then the infrapatellar branch of the saphenous nerve is also one that is very commonly tender. And when we look under ultrasound, it's inflamed. We palpate directly over the branch because we can see it on the ultrasound, and that recreates their pain. And so we end up treating that. And so, yeah, 99% of the time.
Okay. Well, that's a lot of percent of the time. So
Yes.
for folks listening, if you, because I not every clinician out there will look at all the spots outside of the joint. It's like, oh, you've got arthritis. Let's just inject inside the joint, leave it there, and that can definitely be, as Dr. Timmermans is saying here, that can definitely miss a big part of the puzzle, potentially for
Yeah.
folks.
And another comment I'll make, because we've had a lot of patients over the years say, hey, I had PRP and it didn't work. And the other comment I usually make about that is a lot of clinics are not going to care about the dose of platelets that they're injecting. And so there are now level 1 studies showing that that high dose PRP for knee osteoarthritis is really required to give patients the best chance at actually having an improvement in their symptoms. And so there's now been a few meta-analyses that have looked at, they compare low dose PRP studies to high dose PRP studies. And what you consistently see is that low dose studies fail. Those 2 papers in JAMA that got published that said that PRP doesn't work for Achilles tendinopathy, and I don't even remember, I think it was a rotator cuff tear on the other one, very poor quality PRP. Their platelet dose was not sufficient enough. You compare those studies to studies that show benefit, and the biggest key difference here is the dose of platelets. And so if somebody goes to a clinic, whether it's outside the US or even here in the US, and even if they had extra articular outside the joint structures treated and they didn't see a response, one of the first things that I think about is misdiagnosis. So they didn't inject the right structures that were actually causing pain. The second thing I think about is what was the quality of PRP that was dosed. As you know, you do ozone, and so you can't just give them a microdose of ozone and then it doesn't work and then go, oh, ozone doesn't work. No, there's
Mhm.
protocols. There's a dose, right? You have to make sure you're hitting a certain dose in order for ozone to tell somebody this ozone has a very high percent chance that's going to help you. The same thing applies with PRP. The same thing applies with bone marrow, with adipose, all these biologics. I tell patients, it's like if you took 1/8 of a Tylenol for your headache and it didn't help you, you can't say that Tylenol doesn't work because you didn't take the right dose, right? If you take the proper dose of Tylenol and it doesn't work, okay, now we know that Tylenol doesn't work for you. But same thing with biologics. If you inject a mini dose of PRP, you can't say that the PRP was ineffective. It's just that it wasn't dosed properly.
So what would be, say, a minimum effective dose for PRP concentration?
Yeah. So the dentist who was the first one to use PRP here in the U.S. For anything, but also mainly for dentistry, Dr. Marks. He published a paper that showed that around 1.5 billion platelets per milliliter is the kind of minimum dose to stimulate angiogenesis, which is new blood vessel formation. Part of the healing process that we're looking for is stimulating that new blood vessel growth, because where blood goes, healing goes. And so that is the minimum threshold that we're looking at when we are looking at how much PRP per milliliter of blood. And so to give context for the listeners, the average person is going to have about 200 to 400 million platelets per microliter. And so if they're on the high end, or sorry, per milliliter, if they're on the high end at 400 million platelets per milliliter, you're looking at a 4x concentration to get to 1.6 billion platelets per milliliter. Now, if you look at the NEOA studies, the total dose of platelets also seems to matter. Maybe a little less on the actual concentration, but as long as you're hitting 5 billion platelets that are getting put inside the knee joint, that's when you're going to start to see those improvements in knee osteoarthritis. And so if, for example, you have 1.5 billion platelets per ml, you're at least looking at kind of 4 mLs in order to hit that 5 billion total dose that's put inside the knee joint.
Okay, very interesting.
Yeah.
Um, so Dr. Timmermans, I'm just seeing the clock winding down here, and I'm like, I wanted to talk to you about peptides today too, and I know we don't have a ton of time left. So maybe we can switch gears to that quickly if you don't mind.
Yeah, of
I'm
course.
just, yeah, I guess just kind of generally curious because here in Canada, it's very challenging for patients to access peptides, but I know in your neck of the woods and other places it's been more accessible, although you mentioned before we started recording that the FDA made some changes and it's more challenging to access a wider range of peptides these days, unfortunately. Would you be able to maybe speak to your experience with how effective, BPC 157 and thymosin beta 4 has been in your practice? So, say folks maybe if they're just using peptides, what has that been effective for, and how often is it effective? And then if they're using, say, Prolo or PRP or other orthobiologics, how effective is it to add in those extra peptides on top of that?
Yeah, so good question. So first, I'll give the FDA disclaimer here, which is that so back in October, the FDA moved injectable peptides into a category that no longer allows compounding pharmacies to make the peptides in order for them to be sold. And everybody can have their own theories on why this happens, but it's a huge detriment to the population here of chronic pain sufferers because these peptides were so fantastic at helping people. And so right now what that leaves is it leaves a few oral peptides. So BPC 157 is available as an oral supplement here in the US. And then there's a few other oral ones that we use. One of them is a growth hormone secretagogue called ibutamorin, helps improve growth hormone levels, which growth hormone can help with healing of soft tissues. Obviously, we have to be cognizant of the role of growth hormone and IGF-1 in cancer and things like that. And so it's a fine balance there. But that's left people with only either getting the oral or turning to research chemical websites where the peptides are not made in a GMP facility. They're not made in a compounding pharmacy. That means prices are lower. However, these places are not batch testing for endotoxins and other things that contaminants that could be present that can cause a lot of serious health issues. And so I don't advise people to go out and just, search for peptides online and then buy something from a website because it's risky. Most people are going to be fine doing it, but we have seen some very horrific things happen to people when they get dosed with these endotoxins. But when we were heavily using peptides, they were the greatest thing since sliced bread in terms of non-interventional approaches for helping patients to heal from chronic pain. I'll caveat that to say though that I would never just do peptides in replace of some of the core supplements and nutrients that we know to be beneficial for healing. So things like vitamin C, collagen, essential amino acids, and ensuring enough protein intake through the day. Those core things needed to be there in order for these peptides to work so fantastic. But yeah, the peptides were probably in our practice, I'd say helping about 70 to 80% of our patients not have to do a procedure or not have to go down the route of surgery. And then when we added in the peptides on top of, a PRP or a stem cell procedure or Prolo or something like that, we consistently saw that patients rebounded faster from the injection and then also had better outcomes because of that. We don't have hard data on that. There's no published papers on that, but just anecdotally, what we saw with patients is that they were getting a better response when we added in these peptides as part of their post-healing protocol.
Cool. And like with the peptides, like were they Like how often were they needing, like let's say someone had I don't know, moderate arthritis in both of their knees. Actually, let's pick shoulders. Like man, I wanted to
Yeah,
mention
we've been
too,
talking
like
about knees a lot.
I
Yeah, yeah.
know, yeah, like these injection therapies folks, they do apply to like every joint you can think of essentially. So yeah, back, shoulders, wrists, elbows, feet, ankles. So it applies to everything. So let's say someone has moderate arthritis in both of their shoulders, and you thought, okay, they've got the right nutritional supports in place, as you mentioned. How often would they be needing to have an injection of, say, BPC 157? And did you find that BPC 157 worked well enough on its own, or did you usually combine it with TB4? Or yeah.
Yeah, so good question. BPC and TB4 worked really well together synergistically, but BPC on its own is the main workhorse of the peptide world. Like it's just, it's like vitamin C for infections. It's just like everybody needs it, right? And so BPC on its own did really, really fantastic. The way that we would dose them is so we would start them on the protocol, and that protocol was rarely ever just BPC. We would start them on, the supplements and then the few peptides that we might use. And a lot of that was based on patient finances because the peptides from compounding pharmacies are pricier. And so, we would start them on, let's say, supplements plus BPC. Let's say they're symptomatically better at 3 months. We then might start pulling away a few supplements and peptides to gauge how they respond. And so if we pulled out BPC, let's say after being on it for 3 months, and they had no worsening of their symptoms over a 6 to 8 week period, then we would keep them off for a little bit and then maybe trial it again a few months later, once they've reached a plateau and they're healing, and try to see if we're going to get an added response. Or if we took it out and they had their symptoms start to come back, then we know that the daily dosing of BPC is providing them with, a immune modulation slash anti-inflammatory benefit, that it's clearly helping them on a day to day. And then we have to just recognize that, hey, this is more just symptom management as opposed to like truly, healing a tissue. I will say that, while the animal literature does show that, okay, after acute injuries, BPC can help repair that Achilles tendon or a severed nerve or a cartilage injury or whatever it is. Clinically, I didn't see that. It wasn't like we were putting patients on BPC and, they were, we were healing their rotator cuff tears as an example. And you get an MRI a year later and it's like, oh, your rotator cuff tear is healed in that time. That didn't really pan out for us in our experience, but it did help with symptoms and did help with functional improvements and things like that. And so, there are some peptides that we would cycle, right? TB4 was one we would probably cycle a little bit more. So we might be on it for 12 weeks, and we might come off it for a month or two, and then go back on it. BPC was one of those ones where I would be fine if we were staying on it for long term.
And would that be like patient self-injecting every day, or okay?
Yeah, yeah. Generally with BPC, it would be a daily injection. TB4 and TB500, there are some different dosing protocols out there that we've used. We've used a larger dose once a week or twice a week. We've also used the daily dosing. Sometimes we saw the daily dosing work better. Sometimes the, twice a week dosing at a higher dose worked better. Again, we don't really have research studies on that. Interestingly, though, there was a research study on thymosin beta 4 for cardiac fibrosis. So after a heart attack or something like that, and they did a single infusion, and the dose that they used was like 100 times more than what we used in clinical practice. And so that just showed that at least it was safe at the dosing that we were doing. But I think TB4 you can make an argument for doing as a short protocol, just because it's helping with fibrosis and scar tissue formation, and that's only occurring at certain time points in the healing process. And so, but most of the time it would be daily injections.
Gotcha. Well, I know we're pretty much at our time today, Dr. Timmermans, but just before we wind things down, would you mind just sharing with folks where they can find you on social media? And also, if you don't mind just mentioning like your clinic name, and if folks are like, hey, I would travel to see that guy because he seems like a smart cookie, and I'd like to tap into all these goodies that he has access to. Would you mind telling us about where your clinic is, name of the clinic, and I'll put all the info
Yeah,
in the show notes.
Yep. So, clinic name is Regenerative Performance. We're based out of Gilbert, Arizona. Gilbert is probably about 25 minutes from, downtown Phoenix. So people who fly in, most people are going to fly into Phoenix, and we're about 25 minutes from there. In terms of online presence, so the biggest two platforms is probably YouTube and Instagram. I try to direct people over to YouTube because YouTube has great search function. Instagram is good to see the day-to-day stuff and you scroll the feed, but if someone's just like, oh, what has Dr. T said about knee osteoarthritis? YouTube, you can search within the channel and can search knee osteoarthritis, you can search PRP, you can search prolotherapy, whatever it is, and then get stuff that's a little more curated to you. And so Instagram and YouTube, I think if you just search Dr. Drew Timmermans, you'll find me.
Fantastic. Great. Well, thank you so much for taking the time to chat with me today. It was a great conversation. I learned a lot, and I hope listeners learned a lot too.
Awesome. Thanks, Doc. I appreciate you having me on.
Yeah, it's my pleasure. And thank you, folks, for listening to this episode of the Overcoming Chronic Illness podcast. Please stay tuned for the next one.